I think the 5 most common concerns regarding radical prostatectomy for new diagnosis of prostate cancer are number 1 and 2 are kind of linked to the side effects of radical prostatectomy, and it's, what is my control of urine going to be, number 1. Number 2 is, what is my sexual function going to be? In terms of control of urinary function, that is a very, very poorly understood as well as an understood concept in terms of urology. And what I mean by that is sometimes you think you've done a very good anatomic operation, whether it's done open, laparoscopically, or robotically, and the patient has poor urinary control. Sometimes you think you've done an average or poor reconstruction, and sometimes they actually have excellent urinary control. And I think the issue with urinary control, it has to do with what's your control preoperatively, what's your overall fitness level, and what's your motivation to get your urinary control back. In terms of the second most common concern with men post radical prostatectomy, I think it's their sexual function. And it all varies in terms of what the sexual function was before the surgery. Again, one of my mentors told me that if you weren't a great piano player before the operation, you're not going to be a great piano player after the operation. So I think a lot of that has to do with prior sexual function. I think it has to do with the age of the patient. I think it has to do with the motivation of the patient in terms of getting back to being sexually active. And I also think it has to do with the type of disease you have. If you have a very slow-growing, lower intermediate risk prostate cancer, then there is the option of doing what's called a nerve-sparing prostatectomy, either done open, laparoscopically, or robotically, and trying to spare those nerves that run along the prostate. Now, sparing those nerves that run along the side of the prostate is like peeling the skin off an apple. It's a game of millimeters. And when you do that, there always is a risk of leaving the apple behind, which in terms leaves a risk of leaving cancer behind. And it's at the surgeon's discretion in terms of how safe it is to skin this apple, or i.e. nerve spare on this patient. And that's usually a decision made intraoperatively. Even with nerve-sparing prostatectomy, if you do a unilateral versus bilateral nerve sparing, a unilateral nerve sparing only has a 25% chance of having, quote-unquote, the same sexual function prior to surgery, and a bilateral nerve sparing only gives you, I think, a 50% chance of having normal sexual function prior to surgery. Having said that, sexual function does recover over the first year after surgery and over the second year after surgery. So I think the fact that if you don't have good sexual function immediately after surgery, there's still hope. Now, if you have a very aggressive type of prostate cancer, the main objective of surgery is to remove the entire prostate and get every bit of cancer out. And that involves taking the nerves widely and not sparing the nerves. If the nerves are not spared, the chance of achieving a natural erection, unfortunately, is around less than 5%. Having said that, there is many ways to achieve an erection that is, quote-unquote, not natural, either using oral pills, using injections, or using a vacuum device, as well as actually getting an implantable prosthesis placed. So there is ways of achieving erections despite the fact that you may be not able to achieve a natural erection. The third most common concern regarding radical prostatectomy with men is, what is my chance of cure? And I think the chance of cure basically is determined by what the disease is, i.e. what the PSA was at diagnosis, what the Gleasons score was at diagnosis, and what the prostate felt like at diagnosis. That will determine in terms of, radical prostatectomy being nerve sparing, being wide resection, or being done with removing the lymph nodes. For me personally, anything more than an intermediate risk of prostate cancer, i.e. the Gleasons score being 7 or over, or the PSA being greater than 10, I perform usually a wide resection radical prostatectomy with lymph node dissection. Sometimes with a Gleason 7, if I feel the nerves come off easy, I will try to peel that skin off the apple. But if I feel that that's not a safe thing, then unfortunately we have to take the nerves with them. The fourth most common concern regarding radical prostatectomy is, doctor, how do you know if my prostate cancer is cured after surgery? And in prostate cancer, we have a great biomarker, PSA. After surgery, if you are cured of prostate cancer, your PSA will be undetectable. PSA is a protein made by the prostate called prostate-specific antigen, and after surgery, without a prostate or without any prostate cancer, the PSA will be undetectable. And that's how we know if prostate cancer is cured. Sometimes after surgery, the pathology of the final specimen can give us risks of recurrence, etc. But sometimes, even with a bad prostate cancer, with maybe some prostate cancer that's come to the edge, i.e. a positive margin, the PSA will still be undetectable, indicating cure of the cancer. Now, PSA can bump up, and if it bumps up to a level where it starts rising slowly, that indicates that the prostate cancer has possibly returned, and you may need further treatment, i.e. with radiation or hormonal therapy. The fifth most common concern regarding radical prostatectomy is how long am I going to be in hospital for, and how long am I going to wear the catheter for? In terms of hospitalization, it varies between surgeon, between hospital, between health authority. I treat every patient individually. If a patient feels that they're not ready to go home, I won't send them home too early. If they feel they want to go home and I feel it's safe, then I'll let them go home as they wish. Usually, on average, my hospital stays for between 48 to 72 hours. Sometimes a patient will stay for longer. Sometimes a patient will stay for shorter. But after laparascopic radical prostatectomy, expect a 48 to 72 hour hospital stay. In terms of how long do I wear a catheter after surgery, also that's a variable thing. In Europe, it's left longer. In North America, it's left shorter. When I started my practice, I left it for 7 days. Now I leave it for 10 to 14. I feel that there's no rationale to removing the catheter early other than saying that you only have to wear the catheter for 7 days. I always tell patients that you have one chance to heal after surgery. And if you abuse that chance to heal, you might run into complications. So I always am conservative in terms of discharging people too early or taking the catheter out too early. I think if they need to stay a little longer, they can. If the catheter needs to stay a little longer, it should, just to let things heal properly. Everyone heals a little bit differently. Having said that, if someone really is bothered by the catheter and I feel that there's a good anastomosis in terms of reconnecting the bladder to the urethra after the prostate is removed, I will remove the catheter in 5 to 7 days if I feel appropriate.